So we knew it was very important for the safety of our speakers and, of course, you, the attendees. Our event was being broadcast online. But also it is being recorded for you because we realise that the event might be too involved for those of you who might be experiencing the symptoms of long COVID. So in terms of accessing this recording after the event, our event team will be sending out an email with instructions on where it can be accessed on the BU Research YouTube channel. I would suggest that you subscribe to that channel so you can have a notification when that recording is uploaded for you. So generally speaking, so that we can keep to time in this event, the speakers will be shown on camera and audio, but you as attendees won't have the permission to speak or be seen, so you won't be appearing in that recording. We do want to have your views aired though. So throughout this presentation, there are ways in which you can interact with our content, and you can also use the chat box throughout. The chat box is being manned by our research team. So if you have any questions throughout, please post them in there and they will be answered for you. We are hoping that if we run to time, we'll also have time for a question and answer session right at the end. So if you would like to have any questions that you'd like to pose to us to answer for you, please use the Q&A tab which is a Zoom webinar function, and we'll save those and hope to answer them. So what we would say for the safety and the comfort of both our speakers and our delegates is that you please be respectful in your comments. And also in terms with the code of conduct for this event, we'd ask you to avoid speaking about any kind of inflammatory or controversial topics that are polarizing and might make our delegates uncomfortable. For example, talk about vaccines or COVID conspiracy theories. I would like to point out that anyone who doesn't adhere to this, either in our interactive functions or in the chat box, will unfortunately be ejected from the event. We also realise that some of the content that we'll be discussing in this event might be quite distressing for those of you who have lived experience of long COVID. So here we'd like to provide you with some support resources. These will also be sent out after the event as part of the post-event email. So these are generally social media mediated resources, but I'd like to just point out a few things. So if you'd like more immediate support because the event has affected your well-being, then you can phone ME Connect at the ME Association, or you can receive that same immediate support from the Samaritans. I'd also like to draw your attention to one of the resources on here, the Long COVID Advocacy website. So this is being updated routinely, and at the moment it also has a section on there about further resources that you can access and a coping toolkit. So moving on to what we're actually going to discuss in today's session. First of all, I'm going to tell you a bit more about how you can interact with the event via Menti. In the first part of our session, and each of these parts of our overall session are going to last approximately 30 minutes. We'll be talking about the common myths and misconceptions that abound in the media about long COVID. We'll also then be presenting some of our lived experience data, which aims to kind of peek behind the door of the doctor's office to see what kind of healthcare professional interactions people with long COVID and other virus-associated illnesses experience. This will form the backdrop to our panel discussion, and I'm giving the game away a little bit here, but we're going to talk about, well, why are these interactions so distressing and traumatizing for people? How can we improve these experiences for those with virus-associated illnesses? And in the meantime, where can our patients turn? At the end of the event, we would love to hear your views about how it's gone, whether you think there's anything important that we didn't cover, and what we could have done better. This is important for us to improve our own public engagement events, but also for the ESRC in terms of how they can improve the festival overall. So as I said, at the end of the event, you'll get a post-event email. There will be a link in there to a short and self-paced questionnaire where you can provide that evaluation, but also we'll provide a QR code and link in the chat box. So who are we? So we are all involved in kind of qualitative lived experience work with chronic illness populations. Some of us have chronic illnesses. Some of those illnesses are virus associated, myself included. So what I would like to point out, and this might be off-putting to some of you in the audience, is that we are psychologists. But we are academic and research psychologists. We are not clinical psychologists. We all ascribe to biomedical views of the condition. So the symptoms that you're experiencing, if you do have LC, are real. They're very real, and they do not have a psychological origin, nor are they feigned. And therefore, we also don't believe that psychological therapies can provide a cure for any of your symptoms. With the research work that we're presenting in this event, we have obtained funding for it, but we didn't compete for funds that could alternatively have been used for biomedical research that we all, as virus-associated illness patients, desperately need. So as I said, we've got some interactive elements in throughout our presentation. And if you'd like to join in, and it's completely voluntary to do so and also anonymous, then you can do this by following the instructions on this slide. So go to the Menti website and enter this code. Don't worry about noting down this code because it will be presented on all of our subsequent slides. If you do this, you'll be able to kind of poll, you'll be able to provide open-ended comments to those kind of questions. So let's have a go at this interactivity. So for those of you who would like to participate on the Mentimeter and who are logged in, we'd like to get a sense of who you are as our audience. So if you could vote on one of these options, that would be fantastic. So as we suspected, based on the voting so far, we've got quite a mixture. We've got individuals who are affected by LC, and that's the acronym we'll use throughout for long COVID. We have individuals with other virus-associated illnesses, such as ME. So there I'm talking about myalgic encephalomyelitis or chronic fatigue syndrome. And we've got individuals over here just to learn more about these conditions. Thank you for joining us. So let's have a go at just another question. So if your Mentimeter is stuck, you can press go to slide and it will carry on following the presentation as we move forward. So this one requires an open-ended response. And we'd ask that, again, you ascribe to our code of conduct here. So please, if you're writing an open-ended response or comment, please avoid controversial or inflammatory forms of information, but we'd like to find out why you're here, what you'd like to gain from the event. And obviously in our post-event evaluation, we'll find out whether we actually met those aims. Also, with these kind of questions, I'd like to point out that if you don't feel comfortable giving your own response, then what you can do is you can vote on other people's responses, and you can vote on up to 5 different responses. Okay, so the themes here are that people want a better understanding of what long COVID is and what potentially we can do about it, what we as individuals can do about it, what the healthcare system can do about it, how can we cope with this illness, and what is research suggesting, what's in the pipeline, where can we obtain this hope from? Okay, so really the main motivation behind this event was all of us as a research team were seeing that there were kind of a lot of misunderstandings or lack of understandings really about what long COVID or virus-associated illnesses are. And certainly within the pandemic, this was perpetuated by inconsistent or downright inaccurate messaging from the government and health organizations. This has been perpetuated, of course, within the media. So what we want to discuss is some myths, misconceptions about the condition. What we won't do is we won't cover them all, simply because we need to keep this event to time. But again, what I'd like to do is to point out to you that on the Long COVID Advocacy website, soon will be posted a leaflet that is designed for patients to be able to give to their healthcare providers, friends and family members to increase their understanding of long COVID, including a section on myths and misconceptions. misconceptions. So what I'll do now is I'll hand over to my colleague, Dr. Rachel Mosley, who's a principal academic in psychology, to walk you through and invite your participation in this discussion. Thank you.
I'm Rachel. So we would like to start with a brief overview of what long COVID is, just to make sure we're all on the same page, just because there's a few different definitions out there, so people vary in the way they define it. So many health organizations define long COVID as being a relevant diagnosis when someone is experiencing symptoms 4 weeks after an initial acute period of COVID infection. But some health organizations set the bar a bit higher, and they say that you would bestow a long COVID diagnosis if symptoms continue 12 weeks after the initial infection. So when we talk about symptoms continuing, this can be a little bit misleading because the person might not present with all or even some of the same symptoms as they experienced during the acute infection period. So symptoms that you often see in the acute period are fever, respiratory distress, nausea, vomiting, dizziness, fatigue, changes to your sense of taste and smell, though of course it does depend on the strain that you're experiencing. But post-acute infection, someone might experience the emergence of new symptoms. So brain fog is a common one, which sounds somewhat benign on the surface, but actually refers to difficulties in concentration, difficulty storing information in long-term memory, problems with executive function, like your ability to make decisions and organize your time and plan. So the person might also experience symptoms becoming worse or morphing, so old symptoms morphing into slightly new forms. So mild fatigue might increase to a debilitating level where a person really can no longer participate easily or at all in their everyday activities. So you can see a few symptoms here on the screen, which are commonly reported in long COVID, but these aren't intended to be exhaustive. So there's many, many more symptoms that people can experience. But a few things I want to point out from this symptom list you can see here. A few important things are that you can see these symptoms are multi-systemic. So they affect multiple systems of the body. Cognitive dysfunction could be a symptom of the nervous system, the brain, whereas respiratory difficulties could be a symptom of the respiratory system, the lungs, or even the cardiovascular system, the heart and the kind of muscle pushing blood around your body. But they are affecting multiple systems of the body. Secondly, you can see that these symptoms overlap with other conditions. And third, you can see that they have the potential to be extremely debilitating. So this being the case, it's really unsurprising that the majority of people with LC, which is estimated to be almost 2 million people in the UK, they report that the condition impacts on their daily activities. 500,000 suggest that this impact is very, very severe in nature and that it really has limited their lives in a huge way. What's frightening is that these statistics are probably underestimated because our reporting systems are inadequate. And the statistics I've been saying here are from the most recent Office of National Statistics survey from March 2023. So there's going to be a link for that in the chat box right now. So the information that we're taking from this in this event and in this section of the event is coming a lot from a review authored by people with LC, as well as researchers involved in that field. So you'll also be able to find a link to that paper in the chat box now. So now we've covered some key facts about long COVID, we'd like to know what else you already know about it. So I'm going to move us on to some audience participation. I would like to know your thoughts about the statement on the screen now. So particularly, I'd like to know whether you think this is true or false. So if you believe this is true, you'd say yes. Oh, if you believe it's not true, you'll say no. If you're not sure, sometimes you can you can vote as you're doing right now. So that's fantastic. So I'm going to give you just a couple. We've got a very dominant trend here, which is always great to see. And I'm delighted to see this. So I'm going to move this on now to show that the no's have it. So long COVID, it resembles some virus-associated illnesses in that the majority, 2/3 of people affected are women. They're typically between 20 and 40 years old. So to give you an example, there was a study published in Nature Medicine, and it was looking at data from almost 4,200 app users who were basically logging their symptoms. So 15% of women were experiencing symptoms that lasted for 28 days or more, whereas this was 9.5% of men. This sex difference disappeared when people were over 70 years old. So the greatest difference between men and women was really observed in those who were between 40 and 50 years old. And in that age group, women had double the risk of developing long COVID as compared to men. So we know that women are also more prone to autoimmune disease. They are more prone to ME or CFS. And researchers suspect that there might be some overlap between those conditions and LC. So in addition to being more common in women, LC is also more common in those with poor pre-pandemic health, with asthma, or with a range of health conditions such as type 2 diabetes, connective tissue disorders like lupus. We also see higher rates of long COVID in people of Hispanic ethnicity, people who live in bigger bodies, people with low income, and people who were unable to rest in the early weeks after developing COVID-19. So what about the next one? If you've experienced a COVID-19 infection and you didn't develop long COVID, then are you in the clear? True or false? So please do give us your thoughts there. Now, this is we haven't got a single true, which is good. I shouldn't give the answer away there. I'm going to move us on there with that unanimous false, which I'm happy you got it right, but I'm sad that I'm not happy that it's the case, because unfortunately you're correct. If you have got through a COVID infection without developing long COVID, unfortunately you're not out of the woods. It seems that for some people, even while they seem to recover, they maintain what studies call a persistent reservoir of the virus, whole or in its component parts. So you can see this reservoir in signs of abnormal immune function at the time of the first infection, which can predict the development of LC 6 or 7 months down the line. And studies demonstrate that even when people seem to recover, this reservoir of the virus can be found in many organ systems across the body. Viruses have something quite similar to DNA. So essentially, the DNA of the virus can be found in places as random as the eyes, breast tissue, reproductive system, as well as in the brain, and in the respiratory system and the cardiovascular system, even after you've seemingly recovered. It's latent, it's not doing too much, but it's found a home in what's called sanctuary tissue, which is another really horrible term from the research literature. So we still don't know a lot about what the virus does when it's sort of hanging out in your body. It seems that for some people, at least, particles of the virus do pass out of your body with time. However, it seems for some people, part of the reason long COVID symptoms don't show up immediately is that the virus is still causing damage, but some symptoms take some time to develop. This makes sense because damage can be happening in your body before the signs become obvious. Some symptoms only appear after a certain threshold of damage has been reached. Neurological symptoms like brain fog and cognitive decline are much more likely to show up weeks or months after you were initially ill. Pain in the joints and the bones is likely to show up 1 year rather than being present initially. But another reason why long COVID symptoms don't develop initially might be because even if it isn't doing very much while it's dormant, the virus is reactivated by another kind of assault on your immune system. While some people seem to have a period of heightened immunity against COVID-19 after infection, some keep this active reservoir of the virus. And unfortunately, that reservoir, that dormant virus, makes you more vulnerable to reinfection, and your risk of developing long-term symptoms, i.e. LC, increases the more times you get reinfected. In particular, multiple infections might increase your likelihood of developing a form of LC, which very much looks like ME or CFS. Essentially, reinfection seems to reactivate that dormant virus and lead to greater organ and system damage. And unfortunately, other things can also batter your immune system and reactivate the dormant virus. One of these is other viruses. Unfortunately, just like dormant COVID reduces your susceptibility to reinfection, this state of impaired immunity also makes you more vulnerable to other viruses. And to add insult to injury, COVID can also reactivate other viruses that might be dormant in your body without your knowledge. So herpes, Epstein-Barr in particular. So all of these factors mean that someone can develop more persistent symptoms even after apparently recovering. It's also important to mention psychological stress, which triggers an immunological response, the suppression of your immune system. So under conditions of psychological stress, it seems that the blood-brain barrier becomes weaker. This barrier isn't a physical thing, but it's a kind of regulatory force which prevents too much mixing and movement of substances and cells between the body and the brain. And it seems that if you're very stressed, one way that virus-infected cells can damage your body is by passing through the blood-brain barrier so that they can migrate to other parts of the body. So all of this said, it's a bit of a bummer, to put it lightly. So what about this one? Long COVID will only develop in those who have experienced severe symptoms or have been hospitalized. Is this true or false? Again, this is there's not much balance here in the responses. I'll give it another. Yeah, you're 100% right. So what we actually see is that the majority of people with long COVID have not been previously hospitalized with their initial COVID-19 infection. And often they are those who had what's termed a mild acute illness when they initially had the virus. So long COVID is seen across every age of the population, and it varies in severity. The greatest number of cases occur in those who are 36 to 50 years old. Long COVID incidence has been estimated at maybe 10 to 30% of people who were not hospitalized, so i.e. the less severe or mild cases of initial COVID-19. And it's seen in 50 to 70% of people who were hospitalized, i.e. the more severe cases of COVID-19. So that doesn't initially sound quite right, does it? But the fact is that the majority of LC, long COVID cases, are in non-hospitalized people with mild initial COVID infection, because this group make up the majority of all COVID cases. So what do we know about why long COVID happens even after mild acute COVID? Well, when the immune response to COVID-19 is low or absent, along with other signs of insufficient immune responses, this seems to suggest that long COVID might be more likely to subsequently occur several months later in people who are hospitalized and those who are not hospitalized. There are similar rates of cognitive impairments, so separate them would be associated with mental health conditions, which are seen in both hospitalized and non-hospitalized people with long COVID. So damage in brain tissue, reduced brain size, cognitive decline, they've all been noted in people with COVID-19 compared with people without COVID-19. And this is the case in hospitalized and non-hospitalized people, which implicates cognitive damage in long COVID. We might ask, why is long COVID missed following less severe initial cases of COVID-19 infection? Well, there was very much a focus on respiratory symptoms and respiratory damage in COVID-19. And this means that neurological, cardiovascular, and other multi-system effects were often and are often missed. Similarly, we know more about people who've been hospitalized with severe COVID-19 cases than we know about people who weren't hospitalized. Those with milder COVID-19 infections may have more neurological symptoms similar to those seen in ME and CFS. And people with a milder form of COVID-19 also present differently to those with the more severe presentation of COVID. Yet the same tests are used on those patients as the more severe hospitalized people. So what this means really is that symptoms related to neurological and reproductive system, post-exertional fatigue, symptom exacerbation, these are often seen in long COVID, but they tend not to be assessed, sometimes because there aren't tests available to assess them. So we're probably not picking these things up. And what about this one? The symptoms of long COVID present a mild inconvenience to those who are affected. I'm happy to see us start strong out the gate there. So are these symptoms just a mild inconvenience? We're getting a strong answer there. And you're right. So even when long COVID is defined as mild in heavily inverted commas, it can have a massive impact on people. So long COVID can be quite hard to diagnose. The NHS suggests that people must have long COVID symptoms during or after their initial infection, and they must persist for more than 12 weeks and not be explained by other diagnoses. However, to add confusion, different symptoms of long COVID take different amounts of time to appear, as we've mentioned previously. And this is also different in people of different ages. So long COVID symptoms range from the loss of taste and smell, tinnitus, damage to the eyes, symptoms comparable to ME, CFS, organ damage, increased risk of stroke and heart attack due to damage to the vascular system. So it's beginning to become more and more obvious that for many people, this is certainly not a mild inconvenience, and it can be life-changing. So in one study where nearly 90% of the participants described themselves as being in good health prior to their COVID-19 infection, only 2.3%, it's tiny, stated a return to their pre-COVID health. 2.3%. 1/3 of participants said that they had needed to make major changes to their living arrangements as they could no longer care for themselves. Another third reported being able to take care of themselves, but they couldn't get back to pre-COVID interests and hobbies. And for many of these people, this led to a reduction in their ability to work, with approximately 32% now unable to work or on reduced working hours. What's quite interesting is that these differences in functional ability mirror patient classifications in ME CFS, where a taxonomy from mild to very severe is often referred to. And this is echoed in another recent study where participants reflected and expressed how the impact of living with long COVID was impacting every aspect of their lives, resulting in a real sense of fear about what the future held for them. this was worsened by being perceived in a negative light by their doctors. So people felt like their doctors thought they were exaggerating when they talked about how difficult it was for them. And there's some really heartbreaking quotes from the research, which I'm going to give you a couple now. Someone said, "The uncertainty about the duration of the illness is painful. Will I be able to stand up tomorrow? I can't tell colleagues if I'll be back in a week or a year. How can I organize myself?" Another person said, "I used to have a great capacity for work, but now I can no longer work full time because of my symptoms. And this has a huge economic impact on my life." So we'd like to hear from you now around, are there any other myths or misconceptions about long COVID that you're aware of? As before, if you can, try and keep your responses fairly short, just so we can see them on the screen. And please be mindful and respectful of others. If you're not comfortable volunteering any myths or misconceptions, you can vote on the ones that other people submit. Oh, I'm seeing some really good ones. Yeah. Yeah. I'm seeing some which are so frustrating in that, as you point out, they are in the media, they are out there in popular media, they are things that people are being told which are not stacking up to reality. It's all in my head. This again is one that people are, you must be okay, it's just anxiety. Yeah, these are awful, really harmful, damaging misconceptions. We're going to move on and we're going to speak to some of these in our next section. So I'm going to hand back over to Emma, but thank you all so much for your participation in that section there.
Just echoing Rachel, thank you everybody for really interacting with this event. So here we're going to talk about our research findings from our lived experience work, where we really had the question of, well, what are these healthcare practitioner encounters like for people with long COVID and other virus associated illnesses? So keeping up the interactive focus, let's see what your predictions are. Do you think these interactions would be supportive, that people would be met with empathy or not? And I think that's actually really encouraging to see. I personally expected more in the no column than the sometimes column. So I hope that some of you are receiving that good care. So for those of you, and this one's for those of you who have personal or experience with LC, or you know someone who has been infected by LC, can you use just single words to sum up what that experience is like? We're going to create a word cloud. So we want to see if there are kind of trends or commonalities in people's experiences. Frustrating, yes. And whether they're more slanted towards the positive side or the negative side. And here I'm really struggling to find any positive words whatsoever. And I am so sorry that these are your experiences. They are mine too. So despite that, when we went into this investigation to see what these lived experiences were like, we went in with kind of balanced predictions. So there were plenty of reasons to actually be pessimistic about the care that people with virus-associated illnesses would encounter. And really we can look at the historical treatment of people with ME. So usually in lived experience work, you find that not only are these people struggling with very debilitating symptoms, but also they're being stigmatized, their symptoms are being minimized and psychologized by the healthcare professionals that they go to see. But why is the care so substandard? So if you look at medical training associated with virus-associated illnesses in medical schools in the UK, often there isn't any, or there's only an hour of training that these people are given. What is even more interesting is that those doctors who have received some training in post-viral or virus-associated illness actually hold more negative attitudes towards this patient group than those who have had no training whatsoever. So this begs the question, what are these doctors being taught? So mostly within the UK, there is a dominance of something called the biopsychosocial model. This is very light or non-existent on the bio side and suggests that the symptoms that these patients are experiencing are psychological in origin or feigned. And we've seen the biopsychosocial proponents try and place their predictions on many post-viral outbreaks in the past, going back about 50 years into history. And the BPS proponents had a real landmark win with the PACE trial. So here it was a suggestion that individuals with ME/CFS could improve in their condition or even recover if they were to follow a treatment program of combined graded exercise therapy and cognitive behavioral therapy. So graded exercise therapy is the antithesis of pacing. You're taught to find your physical boundaries and ignore them, to push through them. CBT, in this case, when it's complementary to graded exercise therapy, teaches patients to really question and challenge their own illness-related cognitions, for them to question, am I actually ill? So the PACE trial suggested that these therapies were useful for people with ME/CFS, and there is a number of other studies which seem to support this viewpoint, and therefore NICE took up the suggestion that, yes, we'll start saying to doctors that this is what they should be advising ME/CFS patients to do. But at the same time, different patient advocacy groups, different individuals with ME/CFS were basically providing anecdotal evidence that this approach is actually extremely harmful. I'm getting worse, I'm not getting better. And it took a long time for these individuals to be able to convince NICE, almost a decade, that in fact these findings should be retracted, that the evidence of the PACE trial was very poor in the way that they'd recruited people, in the way that they'd tested different outcomes, in the way that they tested improvement. But the PACE trial authors didn't take this lying down. So essentially, still in the popular and the scientific press, you can see these individuals saying that graded exercise therapy and a complementary form of CBT, they should be advertised to these patient groups. And when documented cases of LC started to spring up, well, they'd found a new patient population to apply these same ideas to. So they started to apply for funding to basically have trials where GET and CBT were forced on people with long COVID. Also, long COVID cases started to emerge in the context of the very early part of the pandemic, where the NHS was completely overstretched, understandably, but they also had a very acute healthcare focus. So those of us who were experiencing ongoing symptoms resulting from a virus, we often fell through the cracks. We couldn't even get appointments with our doctors. So it wasn't at all surprising that in the lived experience qualitative research, we began to see that these LC patients were experiencing the same stigmatization, minimization, psychologization of their symptoms that had been previously reported by those with ME. But did we have any reason to hope for a different outcome for individuals with LC? So essentially, when people fall ill with ME, they often do so in isolation, and 80% of cases of ME are post-viral in nature. So speaking to my own experience here, I fell ill with a virus, a fairly benign virus, or so I thought. I engaged in self-care practices, including rest, and I only went to the doctor about 3 months later when those symptoms went unabated or they'd morphed into something drastically different. Often, In these circumstances, the patient only has their anecdotal evidence to say, I had a virus and then this stuff happened. In the context of a pandemic, this link between a virus and these further debilitating symptoms that had morphed was much harder to deny, although I do point out the caveat here that some doctors have attempted to deny this link, particularly for those who felt ill quite early in the pandemic where there was no testing, or people were relying on testing results from LFTs as opposed to PCRs. So what did the patient group do? They were being ignored by doctors, and en masse they took to social media. And we can see that the term long COVID was actually coined on social media by an individual with the illness on Twitter. And beyond that, patients joined together to engage in citizen science efforts, which were really very impressive. So they started to track their symptoms, they started to pull their symptoms, they started to ask what abnormal test results people had had, they started to talk about the biological literature that was emerging. And together, these individuals coming together like this en masse resulted in people taking note. And this is something, particularly in the media, that people with ME hadn't previously experienced before. We hadn't experienced this legitimacy before. In some cases, this meant that the reporting in the media was a bit more balanced. So the caveat here is sometimes it isn't. And I'm sure that those of you with lived experience have seen this. Also, more biomedical funding was springing up to look at post-viral illnesses, which had never been the case before. But the caveat here is some of this research wasn't good quality in nature. We also saw the emergence of long COVID clinics. And these were touted as places where patients could have interdisciplinary workups, they could access referrals, they could access non-standard testing that their GP wouldn't necessarily be able to perform. The caveat here is, of course, the feedback from patients about these clinics suggests they're actually a bit of a postcode lottery. So some people are having to wait ages for referrals. They're not able to actually access those referrals if they don't have a positive test result to show. The support or the treatment they're being given is too short or too small in scope, and they're being discharged and feeling really like they've got nowhere to go. So what did we do? We wanted to kind of look at what our patient experiences. So we took to social media and we recruited approximately 20 individuals with long COVID. Now, because it's very hard to get a diagnosis still to this day for this condition, what we did is we waived that requirement. We suggested if you suspect you have long COVID, you've been ill for approximately 3 months, please do take part. And we wanted to ensure that we had participants from a range of different severities. So we made our questionnaire to gather this data as flexible as we possibly could. So it was self-paced. You didn't have to complete it in one sitting, didn't have to offer a certain number of words. You could record your responses if you wanted to. And this resulted in us having a patient population that did seem to accord to demographics. So 25% of our population suggested they were mild when they looked at the CFS working group taxonomy or descriptions of the condition. 25% suggested that they were severe, and 50% fell in the middle as suggesting they were moderate. We also wanted our study to have a comparative focus. So we asked also a similar number of people with ME to fill in this questionnaire about their experiences with healthcare practitioners. And we asked them to talk about 2 time points, their pre-pandemic care and their post-pandemic care. And this allowed us to be quite comparative in our analysis. So for example, what does the treatment of people with long COVID look like in comparison to the pre-pandemic care that people with ME were experiencing? If that care was better for people with LC than it was for people with ME, then is the situation also improving for people with ME? Are they being kind of dragged along as more is being known in healthcare circles about post-viral illness? And our participants did an absolutely fantastic job in commenting really, really thoroughly on what their experiences had been, both the positive and the negative aspects of their healthcare practitioner care. And our fantastic research assistant, Alex, has been mining the different patterns in these responses. And you can see what our main patterns of responses were here. So on each of these subsequent slides, I'm going to give you examples of anonymized quotes from our participants and talk you through a bit more in depth about these themes. So first of all, and this is possibly not all that surprising to many of you here, they were met by disbelief and misunderstanding psychologization of symptoms. And this was mainly to do with etiology. So a lot of the doctors would wouldn't believe that these symptoms were physical in nature. They suggested they were psychological in nature or feigned. They were offered diagnoses such as anxiety or depression. So what we found is that all of our individuals with ME said that they've met with these attitudes at least once along their healthcare journeys. They suggested that the situation had improved as time has gone on, but we did have quite a large range of illness durations in our sample, from 4 years to 45 years ill, with an average of 13 years. So these individuals suggested, well, it's not because attitudes are changing that I'm getting better treatment now than I was before. It's because I've learned better how to advocate for myself. I've had to shop around for doctors who will actually listen to me. Among our LC participants, it was encouraging to see that only 2/3 of them said that they had been met with these same attitudes. But that's still an awful lot, particularly if these individuals are suffering with such debilitating symptoms that there are huge chunks of their lives that have fallen away overnight. So these attitudes were very much linked to either the health damaging or enhancing advice that these patients received. So what we can see here, and there's a couple of things to pull out, is that most of these individuals, even if they were quite short into their healthcare journey, they were getting quite mixed advice. Sometimes they were getting health enhancing advice. Sometimes they were getting health damaging advice, which was very much tied to this BPS, this biopsychosocial idea that they should be doing more. They'd feel better if they exercised, if they pushed through their boundaries. What we can see encouragingly is that those even quite early in their illness journey, they were able to differentiate between what was good advice and what was bad advice. And we're going to come on a little later to how they are able to do this. And generally it's through the community support or the information they'd accrued from social media. What we can also see here is that, and this isn't particularly well exemplified in these quotes in particular, but most of the time, this health damaging advice was coming from their GPs, their primary healthcare physicians. More sensitive or balanced or conservative or cautious recommendations were being made by those who were kind of complementary to their care, whether it was physiotherapists, specialist nurses, or consultants. We also saw that there was a reluctance to diagnose whether someone was seeking a diagnosis of LC, ME, or just post-viral fatigue. And this is commonplace in the literature with people with ME. So for a number of reasons, doctors are reluctant to diagnose. Perhaps it's because they don't believe in the condition. Perhaps it's because they haven't had enough training to be reassured in their diagnosis. And perhaps it's because they ascribe to these outdated views that these things will resolve in time for everyone across the board. So there's no point having a diagnosis. Particularly in the case of LC, we must remember that not all LC is ME. There are syndromic cases in 52% of cases. At the 6-month mark, most people have the symptoms to receive a diagnosis of ME. But the remaining 48% have a non-syndromic form of long COVID, which according to the literature is more associated with the organ damage to one or various systems. So perhaps these doctors were just being cautious. But what we can see here is that a reluctance to diagnose is really problematic. First of all, it doesn't follow NICE guidelines. So the updated NICE guidelines suggest that if somebody is experiencing these symptoms unabated for 3 months, they are entitled to a diagnosis, rather than the outdated 6-month rule. This means that people can access advice to slow down, to stop, to engage in pacing a bit earlier, which can help to retain a more functional baseline. We can also see that not having a diagnosis is really problematic if you're still in work, for example, if you're still lucky enough to be in work. You can't ask for particular reasonable adjustments. And also not having a diagnosis means, well, what do you tell your friends and family? Are they more likely to believe that this is all in your head? We also saw that there was mixed access to referrals and testing. And of course, this is really important because ME is typically seen as a diagnosis of exclusion. You have to have a number of other tests to rule out other conditions before a diagnosis can actually be given. So generally speaking, people with ME suggested they'd had to wait years for access to further referral and testing. And they'd had to shop around to find doctors who would engage with them in a partnership of care, who would actually respect the knowledge they had about their condition, so that the patient could say, I think I would benefit from this test, for example, and they'd be listened to. What we found was that most people with LC, in our sample at least, had been referred to an LC clinic. Some of them were happy with the additional testing or referral onto consultants they'd had from these services. But a number of people weren't happy. So either they'd had to wait for a very long time, they weren't offered non-standard testing outside of what their GP had already offered them. They were discharged from the services too quickly and left with nowhere to turn. So they had to go back to their GP to request any further treatment. So as I said, this one's a bit mixed. What we did find across the board is that when people felt that they were falling through the gaps, either they've been dismissed by their doctors, or maybe they found a good doctor, but that doctor wasn't able to actually do anything for them, they had no choice but to self-manage their condition. And this was the case, as I said, for people with both ME and LC. And we asked our participants, well, how are you self-managing? And all of them said, I found patient communities online. I've talked to individuals and this has supported my informational needs. So I'm able to ask them, what test might I ask for? Where did you have abnormal results? What consultant might I need to speak to learn more about my condition? What is the current biomedical research suggesting to me? And a lot of the time we saw that these mentorship relationships existed between individuals who had perhaps gone to a particular specialist and they could advise on that aspect, but these were interchangeable. So individuals, as they progressed along their illness journey, were able to act as mentee and mentor, dependent on what the topic of conversation was. And we also saw in these kind of online spaces, a lot of the time, people with ME, virus associated usually, and people with LC, they were able to interact with one another. And a lot of the time, people with ME were warning against the dangers of the poor treatment that they'd encountered, whether it be graded exercise therapy, whether it was things with predominantly or exclusively psychological focus. And people with LC were extremely grateful for this advice. And also on social media, these platforms were used for another couple of aims. And we've seen this in the literature, really. So they were supplying emotional support. Because individuals were scared of viral transmission, they didn't want to risk a reinfection, and also their debilitating symptoms meant they couldn't participate in their lives as usual. They were cut off from face-to-face interactions. And this meant that they, on social media platforms, they had a way to be able to engage with individuals, expending less of their energy and keeping themselves safe. It also taught to validational needs. So individuals were suffering from all of these symptoms all around them. They were being told, this is all in your head, it's not real. And they began to believe this, to self-gaslight. So on these platforms, they could say to individuals, have you had this symptom? Yes, I have. Have you had that symptom? Yes, I have. Okay, so what's happening to me might actually be real. So just to sum up, what I'd like to point out is just a limitation of our research. Obviously, we had quite a small sample size, and this is common in lived experience research because we get such rich data. And also, it might be the case that these individuals are touting the benefits of social media because they're regular users of social media. We derived all our participants from social media sources. It might not look like that for individuals who don't use social media as regularly. So the positives are we can see that there might be less of a reluctance to refer for individuals with LC than there has been in the past with ME. The flip side to this, or the caveat, is that these LC provisions are not all that great. There's a bit of a postcode lottery, and you don't know what you're going to get until you go there. And once you're discharged, what do you do? What's the follow-up? We see that social media groups are serving multiple purposes, but speaking as someone with virus-associated illness, it's extremely difficult to self-educate when you are dealing with pervasive fatigue and cognitive dysfunction. It shouldn't be left to the patients. We've also seen that delegitimization, minimization, psychologization of symptoms, they exist. They continue to exist for people with LC as they did for people with ME. And this is why it's important that the Department of Health and Social Care's recent report suggested that a main drive was to improve the training that medical professionals receive. We also know that late diagnosis, and there still very much is a reluctance to diagnose, can be extremely problematic for people in their occupational settings. If people need financial support, for example, they don't have the leverage of a diagnosis to be able to apply for that. And there's also a suggestion that there's a non-adherence to NICE guidelines in the way that these individuals are being treated. So to further talk about these results and really to get to the heart of, well, what can we do to improve the situation? If we can't get improvements directly through our healthcare practitioners, where do we turn as patients with virus-associated illness? I'm going to pass on to my colleague, Dr. Liam Wignall from the University of Brighton, who's going to talk to our panelists who have both lived and professional experience of virus-associated illness. Thank you for listening.
And listen to the brilliant kind of Emma and Rachel. It was really harrowing to hear your experiences. Thank you so much for all taking the time to kind of be vulnerable and share your thoughts, share your perspectives. Yeah, we really appreciate it. And hopefully you found some of the content that Emma and Rachel have talked about today useful, interesting. And I know that Emily and Faye have been on top of the links and the support of the guides and that kind of stuff. So again, kind of hopefully those resources are supportive. Dr. Charles Shepherd has personal and professional involvement with ME/CFS for over 40 years and has been medical advisor to the ME Association for over 20 years. Having recognized that many people with long COVID exhibit the same type of post-viral disease symptoms as seen in ME/CFS, Dr. Shepherd hopes to identify how research into long COVID can help people with ME/CFS and how ME/CFS patient communities can support and inform people with long COVID about how to manage and navigate their overlapping symptoms. Hopefully that's a good summary, Charles. And then we're also joined by Claire Higham. Claire is an advisor to the Long COVID support group, and her social media handle on various platforms is Long COVID Advocacy, which I imagine some of you are familiar with, where she posts resources and blog posts related to the topic. The link to the support group is being posted in the chat box right now. You can access. Claire is also a member of the Long COVID Patient Advisory Group to the World Health Network. Claire performs these roles by drawing on her academic expertise pertaining to the women's experiences with chronic and medically unexplained conditions within the medical system, as well as personal experience of post-viral illness. Thank you so much for joining. And through the research that we've done and discussed the main findings from our study, I just wanted to kind of ask you both, do the experiences described by the participants match what you've observed and encountered? And maybe, Claire, if we start with you first.
Sure. I mean, definitely. You can see throughout the community that there's a degree of stigma, there's psychologization, there's, damaging advice, and, it kind of varies from people being skeptical that it's an illness to just healthcare practitioners being quite lost and not really knowing quite what to do. So they have someone sit in front of them with long COVID or ME, and they don't have training, they don't have the education, and you can sometimes feel the fear come from them that they just don't know, they don't have the structures and the infrastructure to do what they do. And I think it's a common experience, it's a really common experience. And even if you get a referral on a diagnosis and to go to the clinic, long COVID clinic, they're just often not fit for purpose. So, there isn't really a treatment pathway, you're not really engaging with the medical system, and that leads people to, leave the medical system, which happened to myself. I was very sick with COVID and then long COVID, where I was, classified as severe ME and in bed 24/7 and had a long COVID experience in clinic. And I was, got word brain fog. I was dismissed after 20 minutes, and and that was it. I was out. So yeah, it's a common experience, unfortunately.
And you mentioned kind of the skepticism, but just kind of that on top of the uncertainty by people who are experiencing these things. So it's kind of like this dual, the individual doesn't feel quite prepared for it, and then they come against a level of unpreparedness from medical professionals.
Yeah, absolutely.
Yeah. Charles, how does that relate to your kind of work and experiences?
Yes, I mean, obviously, I've missed the descriptions that your participants have been giving, but from what has just been said, I would agree entirely that this is our experience of the increasing numbers of people that are coming to us at the ME Association, because they've either got the tranche of ME-like symptoms associated with their long COVID, or they've basically got a post-COVID ME/CFS. So it's I think, speaking from my point of view of medical colleagues in both primary care and hospital-based care, I mean, at a primary care level, and I speak a lot to a lot of GPs, I think on the whole they're reasonably okay about making a diagnosis of long COVID, but after that, it's, you know, we just don't know what to do with these patients. I have to say, in some cases, there's a degree of skepticism about you know, how disabling this illness is and the effect that it's having on people. But after, if general practitioners don't feel confident and don't know what to do, they then go. They have this option, obviously, of referring on to either a specialist in respiratory medicine, cardiovascular medicine, or a long COVID clinic if there is one. And again, as has been said, we get a very mixed feedback on people's experiences at the long COVID clinics. I mean, certainly I think this is possibly related to size and the amount of multidisciplinary spread and the expertise that are there. So I think in some of the larger ones, I mean, certainly the one at University College London, this comes through, people do seem to be, you know, very happy with the experience they get. They can go and see a respiratory consultant, they can go and see a dietitian if that's right, they can go and see a physiotherapist who knows what they're doing, they can get some help from an OT. You know, it is a very holistic pattern of care. But at the other end of the spectrum, some people are coming away very disappointed with what they're getting from the long COVID clinics. Apart from getting a confirmation of the diagnosis, they don't feel that they're getting practical help with management, particularly of these, you know, components of long COVID, particularly the debilitating fatigue, the brain fog, and things like POTS, that they're not getting the self-help guidance, the symptomatic treatment that is actually there, and which we've been using in people with ME/CFS to a certain degree of success. So they're missing out on parts of treatment which really they ought to be getting.
Yeah, and we had kind of technical difficulties getting Charles to join. So the main kind of things that Emma spoke about is kind of what you just said there in terms of your experiences around a level of disbelief and misunderstanding from different healthcare professionals, different kinds of advice being given, and sometimes the advice might be harmful to the individuals, the focus on self-management and the need to kind of the emphasis on individuals kind of resourcing their own information on various things, and the benefits of social media in terms of kind of providing that support network.
I think this, because, you know, when I talk to GPs about this and the diagnostic assessment process for people with long COVID, and there's an awful lot of that overlaps with how you would assess a patient with ME. And what I try and put across is that there are these different layers to long COVID. There's obviously the layer of very much post-COVID related, possibly organ damage, but certainly symptoms relating to breathlessness and lung damage, possibly cardiac symptoms, loss of taste, loss of smell, etc., etc. But then you've got this layer of ME/CFS symptoms, your fatigue, your cognitive dysfunction, your POTS, your disturbed sleep patterns, aches and pains, that sort of thing. But on top of that, and I think it's terribly important, is where I think a lot of my primary care GP colleagues are missing out, is this terribly important business of are you making sure that these symptoms are actually long COVID, and that you're not missing out on some other medical, you know, potentially really quite serious medical condition. And for those of us who follow all the stuff in the media on long COVID, will be very aware of these very distressing cases which are cropping up probably about once a month, where someone has been diagnosed even at a long COVID clinic as having long COVID, but in actual fact they've got a malignancy, they've got some other disease which is producing long COVID type symptoms, but because everything started at that point, or roughly a point that when they had COVID, it must be long COVID. So it's terribly important, as with ME/CFS, that the diagnosis is made correctly. And the other thing is, which COVID seems to have a potential for doing, is unmasking other conditions which have not been clinically apparent up to the point of COVID. And in particular, we've got things like diabetes, and certain aspects of heart disease, which COVID seems to be a trigger factor for actually developing. So it is important that GPs, when they're assessing a patient with long COVID, go through this process of doing all these blood tests to exclude things like diabetes and other things which actually could be causing or making long COVID symptoms worse.
Certainly, you kind of highlight the need for more research on the topic. It was something that we were mindful of when we were conducting our own research. How can we incorporate the views of a different range of individuals that allow them to kind of take part in the research? Like, it's difficult. I just want to go on to question 2 now then. So what problems exist in the UK medical system for people with virus-associated illness, and why do these attitudes emerge? Claire, do you want to start with you again?
Sure. You know, there's quite a few problems. This is a big issue, and I think, you know, some of the problems is a lack of education on infection-associated chronic conditions. So, you know, GPs, consultants, the education at medical school and the syllabus is not there. There's a medical bias towards acute, kind of more heroic medicine that was formed, you know, early on, even in the 19th century when medicine was professionalized. And the kind of focus on chronic conditions just isn't there. I mean, you can see even in classical times, doctors didn't want to treat people with chronic conditions. You know, it's not something that paid well or did a doctor's reputation any good. You've also got the lack of funding infrastructure for biomedical research. So it's kind of like the legs of are all missing. You know, there isn't a specialism to support these conditions. And we've also had a huge issue with the mixing of physical and emotional issues, which aren't related. And that's kind of pervaded the kind of medical establishment for the last, well, a couple of centuries, but also specifically within the last 30 years, 30, 40 years. And we've also seen, you know, the misuse of the biopsychosocial model in medical unexplained symptoms that led to, you know, patient harm. So I would say that those are some of the problems that we have. So shall I go on to why, or would you like to?
Sure, and then we can kind of see how Charles' experiences kind of overlap, and I can come in at the decisions.
Sorry, do you want me to plunge in now? Or?
Yeah.
Yes, yeah. Well, I mean, I've been involved personally and professionally with ME/CFS for over 40 years. And when I was at medical school, I was told, this is back in the late 60s at the Middlesex Hospital, I was told that ME/CFS was all hysterical nonsense, go away and forget about it. And it's taken an awful long time, and I think we are now at the point where most doctors actually accept ME/CFS to be a genuine and very debilitating medical condition. But it's taken an awful long time. It's taken an awful lot of battles with entrenched views. And it's also, I think, had a very negative effect on the way in which the medical profession has looked at other post-viral diseases, because, you know, there's a wide spectrum of post-viral disease. It's not just ME/CFS. There's things like post-polio syndrome. There's a very interesting fatigue syndrome, very much like ME, that follows Q fever. It's called Q fever fatigue syndrome. Q fever, for people who don't know, is a bacterial, what we call a zoonosis infection. It's a bacterial infection that people in farmers, vets and whatever, pick up from sheep and goats and whatever. There are a whole range of tropical diseases that produce prolonged symptomatology and ill health. We've got Ebola, Zika, chikungunya, a very interesting one. So there's a whole range of post-viral conditions, actually not only post-viral, they're mainly viral, but post-infectious illnesses which cause prolonged ill health after the viral or bacterial infection has been there. And with the arrival of COVID and long COVID, I think we are now getting a much welcome interest from both clinicians and researchers into looking at this whole aspect of post-viral disease. One of the main problems is just ownership of this, because most of these post-viral disease conditions, as we know from long COVID, cross a whole range of medical boundaries. And as we know with long COVID, this involves respiratory system, cardiovascular system, gut damage, there may be liver damage, kidney damage. So there's a whole range of ologies, a whole range of specialties that need to be involved in this. And you can't just have one ownership amongst a particular specialty of a post-viral disease. So it has to be a multidisciplinary approach. And the way medicine has gone over the past 20 years is to telescope into very tiny ologies and very tiny specifics, whereas here we wanted to widen it out and bring in a whole range of medical specialties, particularly into the services that are providing services for people with long COVID and for people with ME/CFS.
Yeah. Claire, have you got any kind of response to kind of why these attitudes emerged? You mentioned the things around older medical understandings, frameworks, and there was some things in the chat around old medical books, kind of how they spoke about some of these things.
Yeah, so I mean, a lot of it is historical perspective. A lot of my medical colleagues, don't particularly believe that people have, persisting problems after they've had a viral infection. You've had a virus, okay, but it's gone away, so you should be getting better. And I think, here we've got with what's going on with long COVID at the moment and ME/CFS, we don't fully understand what is causing these problems. There's a lot of clues around as to what may be causing long COVID and ME/CFS. It may be due to reactivated viral infection. It may be due to ongoing problems with the immune system response. It may involve problems with what's gone wrong in the brain. There may be what we call low-level neuroinflammation, problems with the autonomic nervous system. There's this range of possible abnormalities in different parts of the body that are going on, which we don't fully understand. And I wouldn't say it frightens some doctors, but it's something that because they don't understand it, they don't get it.
Yeah, it's that uncertainty. Claire, anything to add?
Yeah, sure. So I think the reasons why have these attitudes emerged is quite interesting, and we can look back to like the historic context as well. So you can look at hysteria. You can look at, especially through the 19th century with Freud and Charcot, and we haven't really shaken that off yet. Really, those influences are still present within infection-associated illnesses. You can also, again, it comes back to education, but we've also had the psychiatric agenda that's been pushing a more psychosocial influence, and has used deliberate blocking tactics and has created a powerful infrastructure within the medical system. But then we also have to look at the media as well. So, it's got better with long COVID, but ME traditionally in the media has not been treated well. There's been so many articles that's been damaging. And I think this has created like one of the most kind of serious, influences, because it's that nudge effect. So it's like people kind of have heard, oh, it's kind of in your head, or you need to exercise, and these kind of beliefs kind of pervade through into society and also into medical professionals as well. You kind of think you've heard something, and then this kind of attitude becomes quite pernicious, really. And also, I think we have to look at, how women are treated as well. These conditions affect women significantly. And medicine, and especially medical research, doesn't really treat women that well. They're not really at the table so much. I think, again, it's probably improving a little bit, but you have to look at that underlying medical bias in the research infrastructure and how women's conditions are treated. I think as a woman, any medical condition or pain or that you have, if you go to your doctor, it's going to be much harder for them to even believe you to get like actual practical investigations done and the support needed. So
Yeah.
So.
And it was kind of some of the things that Emma touched on in terms of the focus on the BPS, the biopsychosocial approach. But Claire, I think that's so important about the impact of social media and media in general on attitudes, perceptions, understandings. Yeah, that's really powerful. So we've got a lot of questions, but we won't go through all of them. But the next one, what needs to change to improve the experience of patients with virus-associated illnesses? If we start with you, Charles, this time.
Well, obviously, the first thing is education and information to health professionals. It's something we've been doing in relation to ME, which is, I think, gradually getting through in that education on this subject is now getting into medical schools. We have a new nice guideline on this illness, which came out 2 years ago, which is a vast improvement on what we've had before. But we've still got a long way to go. It's terribly difficult at the moment from point of view of MECFS referral services, getting experienced physicians who can come along and help with these, run these services. And I think to a certain extent it's also there with the long COVID services. So the bottom to all this is improving medical education of doctors and all other health professionals who are going to be involved in managing these patients, and then getting them involved with the specialist services that are going to help these patients.
Yeah, education. Claire, anything else to add?
Yeah, I agree with Charles. We need to kind of rewrite the syllabus and the medical textbooks. We actually need to go back to ground zero and redo those textbooks with a biomedical perspective and get that information in there. But it's not just at medical schools. I do think there needs to be a kind of compulsory professional development courses for doctors and healthcare practitioners that is, especially for long COVID. I mean, the numbers are so huge. And I think, a lot of people go to the doctor and it's like, and understandably, doctors are working really hard. They're really pushed. It's a really difficult situation with the NHS at the moment. But I think with the numbers of long COVID, there has to be an emergency education kind of, put out there. But, I think there's other things that are needed too. Again, it's the funding structure that needs looking at. So, we need that kind of, moonshot approach, with emergency ring-fenced biomedical research funding. And all of it's the infrastructure that's needed. It's kind of bottom up that really needs being put in. So it's the education, the research funding. In a sense, there's a black hole. There's no specialism. So you kind of we need that specialism to be created. And I think with the influx of long COVID, that's really possible. And that again, because it's not, medical medicine tends to have that reductionism where it's kind of going into a fine point. And where one of the issues that's really happened with long COVID or ME is it affects so many parts of the body that, it's kind of counter that method. So we need the specialism with the experts within those specialisms to come together to support people. So that is either specialist clinics or kind of a centre of excellence where these researchers, we saw today actually the early day motion coming in with Clive Lewis feeding into the government for a biomedical centre, for ME, which would be fantastic. And so we see these things are coming slowly, but I think, it's just investment as well. This funding is needed. And also, it's not just the medical health professionals that need educating, it's the public as well. We kind of need a public health campaign that could be done. It's not that hard. I mean, we've seen it done with other illnesses and conditions, and similar with HIV, and kind of we've got to kind of break those doors down, and I think the public needs to understand. And but it takes effort and it takes a lot of money. But I think every other serious disease has these things, and it's so. ME is a really serious illness. The quality of life, and for long COVID, is really, really low. And I think we deserve these structures in place.
Yeah. Can I just add that because I just did a quick bit of research on this morning before coming to the meeting, was that obviously the key source of information for health professionals on diagnosis and management of any condition where this guidance exists is a NICE guideline. And I was part of the committee that produced the new NICE guideline on ME/CFS, and it was interesting. We were finishing that off in 2020, when long COVID obviously started to emerge, and we were starting the pandemic. And we had some, it was very limited interaction, I have to say, with the people at NICE who were preparing the long COVID guideline at the time. And a pretty rapid long COVID guideline from NICE appeared in December 2020. And it was then slightly, it wasn't a great deal of fiddling done to it, but it was updated in November 2021. But it is very disappointing, and I think I'm right in saying there's been no further update. I couldn't find it.
No, there hasn't.
On my search this morning, that there is no change in 2 years from what was put out by NICE on long COVID. And although we haven't made any breakthroughs in understanding and treatment of long COVID, we have learned a lot about good practice as far as what should be happening to patients long COVID, and that is not reflected in a 2021 guideline from NICE. So NICE really needs to pull their finger out here and update the long COVID guideline.
And
that was my last point, actually.
Oh, sorry, Claire.
No, that was my last point as well. So that's, yeah, I completely agree.
I'm glad we're both all on the same wave. And that's kind of one of the main motivations of doing this kind of event today, because Claire, you said like the importance of just generally getting the message out to the general public, to also people that are interested, like Emma and Rachel spoke about the importance of individuals trying to find information out for themselves. So we wanted to kind of really do a lot with this one. Yeah, so hopefully kind of the audience found some useful things from it. Unfortunately, I'm going to have to draw the panel discussions to a close because time-wise, and so annoying because I wish I could kind of ask you both more questions. I just wanted to point out a comment about the new Department of Health and Social Care interim report on ME. We'll post a link in the chat to responses to the report from the ME Association and the Long COVID Advocacy Group. Yeah, are there any kind of very, very quick final thoughts from Claire or you, Charles?
Well, just because you brought up the DHSC,
just a sentence. Sorry.
Report on ME/CFS, which I'm part of. I'm part of the research working group there. I mean, again, just like the NICE guideline on long COVID, the NICE guidelines on ME/CFS, I think you could really do with a DHSC delivery plan on long COVID as well. We were very lucky. We got Sajid Javid involved in this when he was health minister because his niece was affected by the illness, and he drove that forward. It's not a magic bullet, but it's certainly highlighting to government and the medical royal colleges and everything else about what needs to be done in relation to really all aspects of ME/CFS. And I think that something similar for long COVID is needed.
Yeah, absolutely. Thank you so much for your time. I'm going to hand back over to my colleague Emma now, who will wrap up. Thanks again.
Thank you. Thank you for having me.
Hello. So I know many of you have posted questions to the panel and to ourselves, incredibly great questions, in fact, but unfortunately, due to logistics and also due to the fact that many in our audience are suffering from energy limiting conditions, we do unfortunately need to keep to time. But there are additional ways that you can contact us. So here there is a QR code, and we'll also post the link for this post-event questionnaire to the chat box now, where you can tell us what you thought of the event, what could be improved, what wasn't so good. This is flexible and short to complete, and it will also be sent out to you in the post-event email, which we hope will be with you by tomorrow or Monday at the latest. If you have anything additional that you'd like to tell me as the event organizer, please do contact me directly via my email address. I just want to reiterate what else will be sent out in that post-event email. So any of the resources that we referred to, including blog posts and open access articles, will be included in a list of references for you to be able to access at your leisure. And also you'll be instructed on how to access this particular session as a recording. This will be uploaded to the BU Research YouTube channel, which you can subscribe to, get a notification when it's uploaded to there. But you can also share that link with anyone who might be interested in the information we've shared today, but unfortunately hasn't been able to make it. So what I'd just like to say as well is thank you so much to everybody who has been involved in this event, from the speakers to our wonderful tech team and also to our fantastic panelists. Thank you to all of you, most particularly, for joining us here today. And we hope to receive your feedback. As I said, if you'd like to contact me directly, please feel free to do so. Thank you very much, everyone.